Well, it's governments, again, corporations and businesses, people like us. I am not one of these people who believes that there's a conspiracy in the back room with a bunch of guys smoking cigars looking to screw the poor man. I actually don't think that that happens. I think that may have happened in the past. That doesn't happen today. The bodies that are making these decisions look like you and me, and are actually reasonable people working under very unreasonable conditions. And those conditions are that they're driven by essentially institutional processes that respect power and disrespect the lack of power. Institutions take the path of least resistance. If you want to site a waste incinerator somewhere, and we all benefit from it, where does it typically end up getting sited? This happened to us in Alameda County. A medical waste incinerator was sited right in the middle of a low-income community where life expectancy was amongst the lowest in the county. And the community eventually got together and fought it, and we fought with the community, and we managed to get it shut down. But the point is, it came in sort of quietly at night, and then it was just there, spewing out all kinds of stuff. And the question for us was, why did this happen in this community so easily and not in the wealthy community? I mean, imagine that. You wake up next to your mansion and there's a medical waste incinerator. That would never happen. It's actually kind of funny. But why is that? It's because institutional decision makers take the path of least resistance. And that includes public health departments. We do it all the time. We're afraid of challenge. We're afraid of lawyers. We're afraid of controversy. So we try to do the thing that makes the decision happen easily and quietly. And that, unfortunately, is institutional racism, because the consequences that it has are disproportionately impacting low-income people of color. Next slide. And again. Okay, so we all benefit from these users. Who disproportionately has to live next to them? Low-income people of color. Next slide. And of course, we spend a lot of time making brochures that are about this size. Some of them are fancy, some of them are glossy and trifold. But it has to compete against this. This is in essence what we're up against, and we think that brochures are going to win the day. Next slide. This is Alameda County looking at the same gradations of neighborhood poverty level, looking at off-site liquor licenses per 1,000 residents, and you see as poverty increases, liquor sellers increase. Why is that? Well, poverty is stressful, so you need to take the edge off more often, right? And that's just nature, right? No. It's because it's easier to cite these things in these communities because there's less political resistance. Next slide. Okay, so this is the most devastating set of data that I have, and I guarantee you that if you did the same thing for Cleveland, you would find the same thing. But I may be wrong, so somebody prove me wrong, please. This is 4th grade reading scores in the Oakland Unified School District in 2005. They do me the favor of using the same color scheme that I use, red, yellow, and green. Red is reading below basic proficiency. Yellow is at basic proficiency. Green is advanced. Okay, so what I want you to do, and they stratify by African American, Latino, white, and Asian. And you can see in 4th grade, a full third of African Americans are reading below basic proficiency. 2/5 of Latinos, 7% of whites, 14% of Asians. I just want you to keep your eye on the red. These are the kids that obviously we'd be most concerned about. We'd want them to improve. So this is 4th grade. Next slide. This is 8th grade. Next slide. This is 11th grade. So these kids actually seem to be getting worse the longer that they're in the school system. Hit it again. In Oakland, African American and Latino 7th graders read below, hit it again, read below the level of white 3rd graders. That's 4 grade levels. Does anybody think that that doesn't have health consequences? Just raise your hand. And if so, what's our public health strategy for dealing with this? We have none. We wring our hands, oh, that's so terrible, oh, too bad. Maybe a brochure will help. Except I can't read it. Next slide. We don't live in a meritocracy. This is looking at low-income kids and high-income kids, and hit it one time. Now you have the hardest working, smartest low-income kids going to college at a rate of about 78%. Now the dumbest, laziest rich kids, hit it again, go to college at roughly the same rate, hit it again. And some of those kids end up being president. That joke used to be a lot easier before our first. We do not live in a meritocracy. Not going to college has substantial impacts on your ability to earn income and a substantial impact on your ability to pull yourself out of poverty. But there are barriers to low-income kids, no matter how hard they work, no matter how individually responsible they are, no matter how hard they tug on their bootstraps. They're going to be disadvantaged compared to their wealthier peers. The data proves it, not just in education, but in health. But people, for ideological reasons or for their own self-interest, argue that, it's all about individual responsibility. Well, where's your data if you say that? I mean, prove it. I mean, these kids are working hard. They're doing the best they can, and they can't afford to go to college because of the cost, because they don't get the kind of assistance that they need, because the rate of inflation, even while they're in college, is driving them out of college. They've got to work to support their parents. Their parents don't have the equity in their homes because they've lived in redline communities and they haven't built up that equity. So we have this apartheid system where essentially there are these tracks. Some people get on the fast track, some people get on the slow track, irrespective of how hard they work and how individually responsible they are. Next slide. Don't believe me, believe my good friend Bill Gates, who quit his very lucrative job to become a public health practitioner. And he says the American high school system is obsolete. If we keep the system as it is, millions of children will never get a chance to fulfill their promise because of their zip code. In other words, he likes GIS too. Their skin color, race, ethnicity, or the income of their parents, their class. Now he goes on to say that that is offensive to our values, and it's an insult to who we are. So he's calling us out. And we're sitting here in public health and saying, look, Bill, we got brochures, we're doing everything we can. And I know it's offensive to our values, it's an insult to who we are, but we're doing what we can. Next slide. Don't believe Bill, believe the National Institutes of Health. And I tend not to believe them because I don't think they ask the right questions, but on this one they actually got it right. A review of the scientific literature shows associations between education and health across a broad range of illnesses, including coronary heart disease, the #1 killer, many specific cancers, the #2 killer, Alzheimer's disease, mental illness, diabetes, and alcoholism. So education matters in health. Yet our strategies for actually changing the rate of high school graduation, changing third grade reading scores, ensuring that kids have access to preschool education that's high quality, ensuring that kids have access to safe, high quality after school opportunities, we have no practice there. We just sort of wring our hands and say, well, we hope somebody gets to it. And it has health consequences, profound health consequences that are unfair and unjust, and it produces health inequity. Next slide. Okay, so why? Well, hit it like 3 times. We have a set of discriminatory beliefs, both historically and present-day practices, that shape the way institutions make decisions and skew resources towards the powerful and away from the powerless and people of color when they have the opportunity. That affects neighborhood conditions, as well as work opportunities, as well as recreational opportunities, that shapes risk behaviors, that shapes the differential distribution of disease, that shapes the differential distribution of premature death. That's our framework. Our framework is not an effort to explain the universe. It's an effort to explain sort of where we are and how we need to develop interventions. Where are the intervention points that we need to develop in our public health practice to try to change the outcomes that we profess to be concerned about. The #1 goal, increasing life expectancy for all, and the #2 goal of eliminating health disparities. We don't believe that you can get to the elimination of health disparities without focusing some sort of intervention at each of these intervention points.